Welcome. In this session, we'll discuss medical management of glaucoma. Therapy of most glaucoma patients is initiated with medications and or lasers. We'll be discussing lasers in subsequent session. To start with, we'll discuss a little bit on ocular pharmacology. And conjunctival cul-de-sac normally contains 7 to 9 microliters of tears and has a maximum capacity of 30 microliters of tears. Most drops have a volume of 30 microliters to 70 microliters, the average being 40 microliters, so a significant part of the instilled drop may spill out. Of the remainder, a large part is drained by the tears into the systemic circulation via the mucosa of the nasolacrimal passage, and it has been estimated that only 5% of the instilled drop actually penetrates the cornea. Nasolacrimal occlusion by pressing on the lacrimal sac area increases the proportion of the drop available for corneal penetration. Lipid-soluble molecules can penetrate the epithelium and the endothelium of the cornea, and water-soluble molecules can traverse through the stroma of the cornea. So to penetrate the full thickness of the cornea, the molecule has to have both an ionized and an unionized form. And some drugs such as prostaglandin analogues are available in a prodrug form, which is converted to a biologically active form by corneal enzymes. Classifying the drugs according to their mechanism of action is helpful in selecting drugs for patients who need multiple drugs. So drugs decreasing aqueous humor production include beta blockers, alpha-2 adrenergic agonists, carbonic anhydrase inhibitors, and netarsadil. Drugs increasing trabecular outflow include latanoprostene bunod, parasympathomimetics, and ROCK inhibitors ripasudil and netarsadil. Drugs increasing uveoscleral outflow include prostaglandin analogues and brimonidine, and drugs decreasing episcleral venous pressure include apraclonidine and netarsadil. Drugs which act by osmotically dehydrating the vitreous include mannitol and glycerol, and drugs which are said to have a neuroprotective action also include brimonidine and netarsadil. Prostaglandin analogues are the most common first-line agents in glaucoma therapy, and they are available as prodrugs which are converted to their biologically active forms after being hydrolyzed by corneal esterases. They reduce intraocular pressure by increasing uveoscleral outflow, and this is very important to remember. These drugs act on prostaglandin, chiefly PGF2 alpha receptors, activating matrix metalloproteinases to alter the extracellular matrix, thus increasing the spaces between the muscle fibers of the ciliary body. The available drugs include latanoprost, travoprost, bimatoprost, tafluprost, and latanoprostene bunod. Latanoprostene bunod, in addition to having PGF2 alpha agonistic activity, also acts as a nitric oxide donor, which enhances trabecular outflow. So latanoprostene bunod increases both uveoscleral and trabecular outflow, and an intracameral sustained release bimatoprost implant is also approved by FDA. Prostaglandin analogues are meant to be applied once daily, and it has been seen that twice daily application actually reduces efficacy. Prostaglandin analogues reduce baseline IOP by 25 to 33%, and since uveoscleral pathway does not drain into the episcleral veins, prostaglandin analogues can potentially decrease the intraocular pressure below episcleral venous pressure, which drugs acting on aqueous humor production and trabecular outflow cannot. And so prostaglandin analogues can be useful in normal tension glaucoma to achieve a lower target intraocular pressure. Some studies have shown greater efficacy of bimatoprost as compared to latanoprost, and tafluprost is said to be slightly less efficacious, and latanoprostene is said to be slightly more efficacious than the other prostaglandin analogues. Prostaglandin analogues take 4 to 6 weeks to demonstrate maximal effect, and this is very important to remember when advising a patient to come back for follow-up to determine the efficacy of the prescribed prostaglandin analog. The peak effect occurs 12 hours following instillation, and since prostaglandin analog does not have any effect on trabecular outflow, these drugs are also effective in angle closure glaucomas. but co-administration with parasympathomimetics may actually reduce efficacy of these drugs because miotics decrease uveoscleral outflow. Prostaglandin analogues can cause darkening of the iris and the periocular skin. So in this photograph we find a patient having darkening of the right iris as compared to the left iris after application of bimatoprost in one eye only. This effect occurs due to increase in the number of melanosomes within the melanocytes, but the number of melanocytes do not increase. And this effect is more common in iris with concentric heterochromia, having a more brownish region in the center as compared to the periphery. So this effect is more common in mixed colored iris as compared to pure colored iris. This effect is also less common with bimatoprost as compared with latanoprost. This effect is said to be an irreversible change, and since there is no increase in the number of melanocytes, there is no increased risk of melanoma. Another prominent effect of prostaglandin analogues is hypertrichosis, which may be associated with trichiasis and dystichiasis, and hypertrichosis is said to be a reversible change. In this photograph we also find hypertrichosis in the right eye as compared to the left eye. Prostaglandin analogues can also cause a periorbitopathy as seen here in this photograph in a patient applying a prostaglandin analogue in the right eye only, and this occurs due to periocular fat atrophy. And among the constellation of signs, the most important are enophthalmos, a deep upper eyelid sulcus, and ptosis. And periorbitopathy is found to be more common with bimatoprost as compared with latanoprost. Conjunctival hyperemia due to conjunctival vasodilatation can also occur with prostaglandin analogues, and it is more common with latanoprostin, bimatoprost, and travoprost. And a lower concentration of bimatoprost is now available to reduce the incidence of conjunctival hyperemia. Prostaglandin analogues can induce or promote cystoid macular edema in eyes with aphakia, pseudophakia with ruptured posterior capsules, and uveitis. They have also been linked with reactivation of herpetic keratitis and a non-granulomatous anterior uveitis. Flu-like symptoms, joint pains, and headaches can also occur following instillation of prostaglandin analogues. And the relative contraindications of prostaglandin analogues include uveitic and neovascular glaucomas, which are associated with inflammation, cystoid macular edema, and herpetic keratitis. Beta-adrenergic antagonists or beta blockers lower intraocular pressure by reducing aqueous production by blocking beta receptors, particularly beta 2 receptors in the ciliary epithelium, thus decreasing cyclic AMP production. And the beta blockers available include timolol, betaxolol, cartiolol, metipranolol, and levobunolol. And among these, only betaxolol is beta 1 selective, and though is less effective in lowering intraocular pressure, it causes less systemic adverse effects. And timolol 0.25% has been shown to be equally efficacious as timolol 0.5% in majority of patients. Beta blockers are typically prescribed twice daily, and once daily administration may also be feasible. And beta blockers, whether applied once or twice daily, should be applied first thing in the morning so as to blunt the early morning rise in intraocular pressure while minimizing the risk of systemic hypotension during sleep. Beta blockers reduce intraocular pressure by 20 to 30%, and due to significant systemic absorption, application in one eye results in IOP lowering in the other eye also. In addition, plasma levels following topical application have been found to reach levels similar to that following systemic administration of beta blockers. Gel formulations containing 0.1% timolol to be applied once daily, as well as closure of eyes and nasolacrimal occlusion following instillation of drops, decrease systemic absorption, and this is more important with beta blockers than with prostaglandin analogues, which have much less systemic adverse effects. Aqueous production starts to decrease within 1 hour following instillation of a single drop, but may last up to 4 weeks. Reduction in aqueous production with beta blockers results in a compensatory decrease in trabecular outflow, and this is said to dampen the overall IOP lowering efficacy of beta blockers. Beta blockers are not effective in lowering intraocular pressure during sleep, as aqueous production is already low during sleep, and this may be important in patients who experience systemic side effects of topical beta blockers such as hypotension and bradycardia, which in turn may decrease ocular blood flow. So there is a potential for imbalance between intraocular pressure and ocular blood flow at night time with beta blockers, which may predispose to further progression of glaucoma. Topical beta blockers may be less effective in further lowering intraocular pressure when administered to patients already taking moderate to high dose of systemic beta blockers, and this is very important to remember. Loss of efficacy of beta blockers with time has been described. A short-term escape can occur in a few days following initiation of therapy, and a long-term escape can occur starting 3 to 12 months after initiation of therapy. The two important adverse effects of beta blockers are bronchospasm and worsening of heart block. Bronchospasm occurs through inhibition of beta 2 receptors and is less common with the beta 1 selective betaxolol. Cardiac effects include bradycardia, worsening of heart block, systemic hypotension, and reduced exercise tolerance, and this occurs through inhibition of beta 1 receptors. Cartiolol, which is an intrinsic sympathomimetic agent, may have less cardiac side effects. The most frequent adverse effects of topical beta blockers arise from CNS depression, but they are more difficult to identify and include lethargy, mood changes, and depression. Beta blockers can cause reduced glucose tolerance and masking of hypoglycemic symptoms and signs in diabetics, and they may also cause alteration in lipid profile, particularly reduction in HDL. Following abrupt withdrawal of beta blockers, hyperthyroidism may worsen. Beta blockers may also cause induction or worsening of myasthenia gravis and impotence. And among ocular side effects of topical beta blockers, corneal anesthesia, punctate keratitis, and pseudopemphigoid have been described. Pseudopemphigoid is a conjunctival cicatricial disorder resembling ocular cicatricial pemphigoid, and granulomatous anterior uveitis has been reported with metipranolol. So in contrast to prostaglandin analogues, with which local side effects are much the more common and systemic side effects are infrequent, with beta blockers, systemic side effects are more common and more serious as compared to ocular side effects. Contraindications to topical beta blocker use include asthma, chronic obstructive pulmonary disease, bradycardia less than 55 per minute, second or third degree heart block, and congestive heart failure. So checking pulse rate prior to prescribing a topical beta blocker is very important. And the respiratory and cardiac contraindications of beta blockers are very important to remember. Other contraindications to topical beta blocker use include myasthenia gravis, diabetes mellitus, impotence, current or previous use of antidepressants, children in whom relatively high systemic drug levels may be reached, and because of significant risk of apnea, which we will see is more common with alpha-2 adrenergic agonists, and patients undergoing allergy test or desensitization in whom, if anaphylactic reaction occurs, usage of beta blockers will interfere with the treatment of the anaphylactic reaction. Alpha-2 selective adrenergic agonists lower intraocular pressure primarily by inhibition of aqueous production. Stimulation of alpha-2 receptors lead to decreased production of cyclic AMP, and we have seen that decreased production of cyclic AMP is also the mechanism by which beta blockers work. After a longer period of therapy, brimonidine increases uveoscleral outflow by relaxing ciliary muscles. Brimonidine is said to have a neuroprotective effect, which may be important in normal tension glaucoma. The other alpha-2 selective adrenergic agonist apraclonidine does not have any effect on uveoscleral outflow, but has been shown to reduce episcleral venous pressure. The two alpha-2 selective adrenergic agonists include brimonidine and apraclonidine. Brimonidine is the alpha-2 selective adrenergic agonist used for long-term therapy. Apraclonidine is not used long term because of tachyphylaxis and a very high incidence of blepharoconjunctivitis, and so use of apraclonidine therapy has been restricted for perioperative therapy for laser procedures such as iridotomy, trabeculoplasty and capsulotomy, as well as cataract surgery. Brimonidine is usually dosed 3 times daily but may be dosed twice daily, particularly when another drug is also used. The peak IOP reduction achieved with brimonidine is 26%, which occurs 2 hours after application. Brimonidine does not show tachyphylaxis, unlike the two other drug classes which act on aqueous humor production. Beta blockers and carbonic anhydrase inhibitors, alpha-2 selective adrenergic agonists, have no effect on nocturnal intraocular pressure because aqueous humor production is normally reduced during sleep. Efficacy of 0.15% and 0.1% brimonidine with sodium chloride, which is a safer preservative than benzyl alkonium chloride, is similar to brimonidine 0.2% with benzyl alkonium chloride. Brimonidine also has a systemic crossover effect in the fellow eye, but the effect is small compared to beta blockers. The most important adverse effects of alpha-2 selective adrenergic agonists are hypersensitivity reactions, including follicular conjunctivitis and contact blepharodermatitis. These are delayed type hypersensitivity reactions and dose dependent, so they occur several days to few weeks following initiation of therapy. The incidence is 20% with brimonidine and much higher with apraclonidine, and the incidence continues to increase with time. These side effects are less common with lower concentration of brimonidine and containing sodium chloride as preservative instead of benzyl alkonium chloride. Although these drugs are relatively selective for alpha-2 receptors, they do have some alpha-1 receptor adrenergic effect, resulting in mydriasis, conjunctival blanching and lid retraction. And this is why sometimes brimonidine drops are used intraoperatively to reduce conjunctival bleeding during glaucoma and cataract surgeries. Apraclonidine, which is relatively less selective for alpha-2 receptors, more commonly show alpha-1 adrenergic effect, and brimonidine, which is more alpha-2 selective, more commonly causes miosis instead of mydriasis. Among the CNS effects of alpha-2 selective adrenergic agonists, dry mouth and lethargy are the most common, but the most serious are apnea, hypotension and bradycardia when these drugs are instilled in infants and young children, and this is very important to remember. CNS effects are more common with brimonidine, which can cross blood-brain barrier, and granulomatous anterior uveitis has also been reported with brimonidine use. So alpha-2 selective adrenergic agonists should not be used in infants and young children, and they are also contraindicated in patients using monoamine oxidase inhibitors and tricyclic antidepressants, which may potentiate the systemic side effects of these drugs. Non-selective adrenergic agents such as epinephrine and dipivefrin are no longer used because of frequent occurrence of local adverse effects with the usage of these drugs. Carbonic anhydrase inhibitors lower intraocular pressure by reducing aqueous humor production by inhibiting carbonic anhydrase enzyme in the ciliary epithelium. Bicarbonate produced by the carbonic anhydrase enzyme is actively secreted from the ciliary epithelium into the posterior chamber, followed by osmotic transfer of water into the posterior chamber, and more than 90% of the carbonic anhydrase enzyme in the ciliary epithelium must be inhibited before IOP reduction occurs. In addition, systemic carbonic anhydrase inhibitors may decrease sodium-potassium ATPase activity in the ciliary epithelium through metabolic acidosis. So there are both topical and systemic carbonic anhydrase inhibitors, and topical carbonic anhydrase inhibitors include dorzolamide and brinzolamide. The topical carbonic anhydrase inhibitors have much less systemic side effects as compared to the systemic carbonic anhydrase inhibitors, and so they can be used long term. Topical carbonic anhydrase can be dosed 3 or 2 times daily, and most clinicians initiate therapy 2 times per day and increase to 3 times per day if required. Systemic carbonic anhydrase inhibitors include acetazolamide and midazolamide, and they are reserved for short-term use only in patients with severely elevated intraocular pressure for control of intraocular pressure prior to surgery and in patients who cannot or do not want to undergo surgery. Long-term use of systemic carbonic anhydrase inhibitors should be avoided. Midazolamide is metabolized by the liver, whereas acetazolamide is excreted unmetabolized by the kidney. So acetazolamide should not be given in a patient with impaired renal function. Systemic carbonic anhydrase inhibitors can be administered orally or intravenously. And orally we have standard acetazolamide formulation whose full dosage is 250 mg 4 times daily. Then there is sustained released acetazolamide whose full dosage is 500 mg twice daily, and midazolamide whose full dosage is 25 to 50 mg 2 to 3 times daily. Full dosage of systemic carbonic anhydrase inhibitors need not be given, and the lowest possible dose, which is sufficient to control the intraocular pressure adequately, should be given. Topical carbonic anhydrase inhibitors reduce intraocular pressure by more than 20%, and like other aqueous production inhibitors such as beta blockers and alpha-2 selective adrenergic agonists, carbonic anhydrase inhibitors have no effect on nocturnal intraocular pressure. And addition of a topical carbonic anhydrase inhibitor in a patient taking full dose of a systemic carbonic anhydrase inhibitor is of no benefit. Systemic carbonic anhydrase inhibitors reduce intraocular pressure by more than 30%, and the oral agents start to act within 1 hour and take 2 to 4 hours to have full effect. Sustained release preparations act longer and take 3 to 6 hours to take full effect. And it has been observed that most rapid onset of action with systemic carbonic anhydrase inhibitors is obtained by administering 2 tablets of the standard formulation 250 mg acetazolamide at once. Midazolamide has lesser efficacy in lowering intraocular pressure but has a longer duration of action as compared to standard acetazolamide formulation. Midazolamide and sustained released acetazolamide is better tolerated than standard acetazolamide formulation. Acetazolamide can also be administered intravenously, and intravenous acetazolamide take 15 minutes to start effect. Topical carbonic anhydrase inhibitors cause burning on instillation, and this is particularly common with dorzolamide, which is formulated at a low pH. Brinzolamide preparations have a pH nearer to physiological tear pH and are more easily tolerated. Carbonic anhydrase inhibitors, because of their action on the ciliary body, may induce myopia, causing blurring of vision, and blurring of vision can also occur due to the suspension nature of brinzolamide preparations. Topical CAIs may also cause punctate keratitis, white deposits in the tear film with brinzolamide suspension, corneal decompensation in eyes with compromised endothelial function, and this is very important to remember. Taste disturbance, which is the most common systemic side effect of topical carbonic anhydrase inhibitors and can be reduced by nasolacrimal occlusion. And unlike systemic carbonic anhydrase inhibitors, topical carbonic anhydrase inhibitors are not known to cause acid-base or electrolyte imbalance. Adverse effects of systemic carbonic anhydrase inhibitors are important to remember, and most adverse effects of systemic carbonic anhydrase inhibitors are related to metabolic acidosis caused by these drugs, and these adverse effects are dose-related. Midazolamide causes less metabolic acidosis and so are better tolerated. These adverse effects include paresthesias of fingers and toes, which is almost universal, lethargy, depression, anorexia, weight loss, decreased libido and impotence, taste disturbance, particularly a metallic taste, especially with carbonated beverages, nausea, abdominal pain and diarrhea, raised urinary pH which may lead to enuresis, calcium oxalate and calcium phosphate renal stone formation, and decreased excretion of ammonia in hepatic cirrhosis leading to hepatic encephalopathy. In hepatic cirrhosis, ammonia is not converted to urea and the excess ammonia needs to be excreted by the kidneys, and increased urinary pH inhibits this excretion of ammonia, which may lead to hepatic encephalopathy. And with systemic carbonic anhydrase inhibitors, sickling crisis can occur in patients with sickle cell anemia because of metabolic acidosis. Other than the adverse effects caused by metabolic acidosis, hypersensitivity reactions can also occur with the use of systemic carbonic anhydrase inhibitors, and they include allergic reactions, but it has been observed that only 10% of patients with allergy to sulfonamide antibiotics experience allergic reaction to sulfonamide non-antibiotics. And this is because the portion of the sulfonamide molecule most responsible for inducing allergic reactions is not present in carbonic anhydrase inhibitors. Other hypersensitivity reactions include Stevens-Johnson syndrome, blood dyscrasias, which is very important to remember, and hepatic necrosis. Among blood dyscrasias, it has been observed that agranulocytosis and thrombocytopenia are reversible, but aplastic anemia is not and is frequently fatal. And it is well known that periodic routine blood counts cannot predict occurrence of blood dyscrasias with systemic carbonic anhydrase inhibitors. Systemic carbonic anhydrase inhibitors can also cause hypokalemia, which is not related to metabolic acidosis or hypersensitivity reactions, and this occurs particularly in patients using diuretic agents, particularly thiazide diuretics. Contraindications to using topical carbonic anhydrase inhibitors include endothelial decompensation and sulfonamide hypersensitivity. And contraindications to the use of systemic carbonic anhydrase inhibitors include sulfonamide hypersensitivity, renal impairment, hepatic impairment, sickle cell disease, in diabetic patients prone to ketoacidosis, and in patients using thiazide diuretics. Parasympathomimetic agents or myotics were the earliest anti-glaucoma medications available, but are used very infrequently presently, and they have two mechanisms of action. By causing contraction of the longitudinal ciliary muscle fibers, it increases trabecular outflow, which is helpful in open-angle glaucoma. This occurs because these longitudinal ciliary muscle fibers are attached to scleral spur, trabecular meshwork, and the Schlemm's canal, and on contraction of these longitudinal ciliary muscle fibers, the intertrabecular spaces open up and the Schlemm's canal dilates. Parasympathomimetic agents also cause contraction of the dilator muscles of the iris, and this helps in widening a narrow angle in angle closure glaucomas. On the other hand, parasympathomimetic agents may decrease uveoscleral outflow, which occurs through the ciliary body. Parasympathomimetic agents can be direct acting agents or indirect acting agents. Direct acting agents act directly on muscarinic cholinergic receptors, particularly the M3 receptor. Direct acting agent available is pilocarpine, and it is available in various concentrations ranging from 0.5% to 4% and are prescribed 2 to 4 times daily. Lower concentration dosed less frequently improves compliance because of frequent occurrence of local and systemic adverse effects. Indirect acting agents inhibit cholinesterase, thereby potentiating the action of naturally secreted acetylcholine, and ecothiophat is the indirect acting agents available. It is rarely used now because of its ocular and systemic side effects. Carbachol is a dual-acting parasympathomimetic agent which can both directly stimulate the M3 muscarinic receptor and also inhibit cholinesterase. Pilocarpine reduces intraocular pressure by 20 to 30%, and the IOP lowering efficacy is dose dependent. It is used infrequently presently, and indications include plateau iris syndrome, aphakic glaucoma, blunting exercise-induced intraocular pressure spikes in pigment dispersion syndrome, and also to induce miosis intraoperatively during glaucoma surgery. Ocular adverse effects of parasympathomimetic agents include miosis and ciliary spasm, which may cause induced myopia, brow wake, difficulty in vision in dim illumination and with cataracts, increased risk of retinal detachment, intraoperative bleeding, and severe post-operative fibrinous reaction. And indirect parasympathomimetic agents are known to cause iris pigment epithelial cysts, particularly in children, pseudopemphigoid, punctal stenosis, and cataracts. Systemic adverse effects of parasympathomimetic agents are infrequent but are more common with indirect acting agents, and they include bronchospasm, atrioventricular block, and also increased salivation, sweating, and enuresis, as well as abdominal cramps, nausea, vomiting, and diarrhea. Contraindications to the use of parasympathomimetic agents are important to remember, and they include phacomorphic glaucoma, malignant glaucoma, and other angle closure glaucomas with a posterior pushing mechanism, because in these situations, ciliary muscle contraction caused by parasympathomimetic agents can cause further forward displacement of the lens iris diaphragm, resulting in further narrowing of the anterior chamber angle. Presence of ocular inflammation such as is found in uveitic glaucoma and neovascular glaucoma is also a contraindication to the use of parasympathomimetic agents, and depolarizing muscle relaxants such as succinylcholine should not be used within 6 months of stopping indirect acting parasympathomimetic agents, which by inhibiting cholinesterase can potentiate the action of depolarizing muscle relaxants. Rho kinase inhibitors or ROC inhibitors are a new group of drugs available for treatment of glaucoma, and they lower intraocular pressure by increasing trabecular outflow by inhibiting the enzymes Rho kinases. Rho kinases, by promoting cross-bridging of myosin side chains with actin, increase stiffness of the cytoskeleton of the cell, and this increase in cell stiffness also occurs in trabecular meshwork cells. And Rho kinase inhibitors, by inhibiting Rho kinases, relaxes these cells, thus improving trabecular outflow. The available Rho kinase inhibitors are ripasudil and netarsudil, and both have ROC1 and ROC2 inhibitor activity. Netarsudil also has norepinephrine transporter inhibitory action, which is said to further lower intraocular pressure by decreasing episcleral venous pressure and also decreasing aqueous humor production. Netarsudil is also said to have a neuroprotective effect. Ripasudil is dosed twice daily and netarsudil is dosed once daily. Rho kinase inhibitors have been found to decrease intraocular pressure by 20%, and most trials of Rho kinase inhibitors have been done in patients with only a mild elevation of intraocular pressure. So efficacy of Rho kinase inhibitors are modest in comparison to other anti-glaucoma drugs, but studies show that some patients do respond very well to Rho kinase inhibitors. The most common adverse effect with Rho kinase inhibitors is conjunctival hyperemia, which can occur in more than 50% of patients being treated with Rho kinase inhibitors. Conjunctival hyperemia occurs due to conjunctival vascular smooth muscle relaxation, and it occurs in the first few hours after instillation of the drug. So netarsudil, which is dosed once daily, is prescribed to be applied at bedtime. Corneal verticillata or vortex keratopathy is also a common side effect of Rho kinase inhibitor therapy. Fixed dose combinations are commercially available preparations that contain two anti-glaucoma agents, so they increase compliance to therapy and decrease preservative exposure. Fixed dose combinations usually have similar efficacy and also have similar side effects apart from reduced preservative exposure as when compared with the individual drugs being instilled separately. And before prescription of a fixed dose combination, it is recommended to ensure that each agent further lowers intraocular pressure by adding them sequentially one after the other. Available fixed dose combinations include combinations of a beta blocker with either a prostaglandin analog or an alpha-2 selective adrenergic agonist or a carbonic anhydrase inhibitor. The prostaglandin analog beta blocker combinations are prescribed to be applied once daily, while the other combinations are prescribed to be applied twice daily. These fixed dose combinations have been found to reduce intraocular pressure by 25 to 30%. Fixed dose combination of brinzolamide and brimonidine are prescribed to be applied 3 times daily, and IOP reduction by this fixed dose combination can be as high as 36%. A fixed dose combination of latanoprost with netarsudil is also available, and it is prescribed to be applied once daily at night time, and IOP reduction by this combination has been found to be as high as 37%. Hyperosmotic agents are used to lower intraocular pressure in acute situations with severely elevated intraocular pressure, and these drugs lower intraocular pressure by increasing blood osmolality, which draws fluid from the vitreous cavity. So hyperosmotic agents act on the vitreous cavity and has no role in aqueous humor production or aqueous humor outflow. The hyperosmotic drugs include mannitol 20% to be administered intravenously, with the dose being 0.25 to 2 grams per kilogram of body weight to be administered over 30 to 60 minutes, and glycerol 50% to be administered orally, with the dose being 1 to 1.5 grams per kilogram of body weight. Hyperosmotic agents are very efficacious in the short-term treatment of acute elevation of intraocular pressure, and both intravenous mannitol and oral glycerol start acting within 10 minutes, with their peak action occurring in 30 minutes and action lasting for 5 hours. The larger the dose and the quicker it is given, the greater is the IOP lowering effect. And the IOP lowering effect decreases over time because of redistribution of fluid between the vitreous and the blood compartments. Hyperosmotic agents are less efficacious in eyes with disrupted blood aqueous barrier, because then the drug enters the vitreous cavity and may actually cause rebound increase in intraocular pressure by drawing fluid into the vitreous cavity. The most important among the adverse effects of hyperosmotic agents is acute congestive cardiac failure, and myocardial infarction can also occur, and these occur because of rapid increase in cardiac preload and is more likely to occur with intravenous mannitol. Other adverse effects which are known to occur with hyperosmotic agents include subdural and subarachnoid hemorrhages, urinary retention, pulmonary edema, headache, backache, confusion, fever and chills, nausea, vomiting and diarrhea. Glycerol may cause hyperglycemia and ketosis in uncontrolled diabetics because glycerol metabolizes to glucose and ketone bodies. Hyperosmotic agents may also cause anaphylactic reaction. And contraindications to hyperosmotic agent therapy is important to remember and includes renal failure, cardiac failure and uncontrolled diabetes. After discussing the individual classes of anti-glaucoma agents, we will now discuss the general guidelines for medical therapy of glaucoma. For long-term therapy of open-angle glaucoma, the aim of therapy is to reduce intraocular pressure to an extent at which the structural and functional glaucoma status remains stable or progress very slowly during patient's lifetime. And the indicators of structural and functional glaucoma status include serial optic disc photographs, analysis of retinal nerve fiber layer thickness with OCT, and visual field analysis. Prescribed medicines to an individual patient should be effective, affordable, easy for the patient and the family to follow, and have lowest risk and fewest adverse effects. Medical therapy of glaucoma is usually started with a single anti-glaucoma drug unless the initial intraocular pressure is very high, and as we have mentioned, prostaglandin analogues are the most common first-line agents used because of their ease of use with once daily dosing, superior efficacy and minimal adverse effects. Beta blockers, which may have significant systemic adverse effects, are also an option for initial therapy when cost of therapy is an issue, and if prostaglandin analogues and beta blockers are not effective in lowering intraocular pressure in a patient, then another class of drug can be used as initial therapy. Unilateral treatment trial is often indicated to determine efficacy of the drug, but evidence suggests that it is of little value. If with a single drug the target intraocular pressure is not achieved, then another drug is added to the first drug if the intraocular pressure has been significantly lowered with the first drug, and if the first drug does not lower the intraocular pressure significantly, then the first drug is withdrawn and another drug is prescribed. And when another drug needs to be added to the first drug, it has been seen that the additive intraocular pressure lowering effect of most other classes of drugs such as beta blockers, alpha-2 selective adrenergic agonists, topical carbonic anhydrase inhibitors and kinase inhibitors in a patient already on a prostaglandin analog are more or less the same. and the additional drug is selected based on its adverse effect profile and the presence of contraindications in the patient. If 3 or more drugs are required to control the intraocular pressure adequately, compliance becomes poor, risk of adverse effects including preservative toxicity increase, and the additive IOP lowering effect of the additional drugs decrease. Fixed dose combinations can improve compliance and lessen preservative toxicity but does not diminish risk of the other adverse effects. In patients with worsening disease following a period of long-term stability with medications, a reverse uniocular trial by stopping medication in one eye only can help us to determine whether the worsening of the disease is due to loss of efficacy of the drug or due to progression of the underlying disease. When the worsening of the disease is due to loss of efficacy of the drug, stopping medication in one eye will result in no significant change in intraocular pressure in that eye, and in this scenario there is a need to change the drug. And when the worsening is due to progression of the underlying disease, stopping medication in one eye results in further rise in intraocular pressure in that eye, and in this situation there is a need to add another drug. Management of ocular surface damage in glaucoma patients is very important, which occurs due to preservative or drug toxicity. When there is significant ocular surface damage, we should change over to another anti-glaucoma preparation with a safer preservative or in a preservative-free formulation. And if glaucoma status allows, we may stop the topical anti-glaucoma drug for a few days and treat with frequent artificial tears. During this period, oral carbonic anhydrase inhibitors can be used if required. And if ocular surface damage is severe, laser or surgical therapy for glaucoma should be considered. In acute severe elevation of intraocular pressure, aims of lowering intraocular pressure with medications include protection of the optic nerve till definitive treatment is administered, clearing of the cornea, making the iris responsive to myotics in preparation for laser iridotomy, and reversing collapse of Screm's canal and collector channels. And drugs used in lowering acute severe elevation of intraocular pressure include hyperosmotic agents and systemic carbonic anhydrase inhibitors. Instructions which we should give to the patient regarding instilling eye drops include appropriate installation of the eye drop in inferior cul-de-sac, keeping a gap of at least 5 minutes between two drugs, performing nasolacrimal occlusion by pressing on the lacrimal sac area and or gentle closure of the eyes for 1 to 3 minutes immediately after installation of a drop, which increases ocular contact time and corneal penetration and decreases systemic absorption, and is particularly important for beta blockers, alpha-2 adrenergic agents, and topical carbonic anhydrase inhibitors. This also ensures adequate gap between installation of two drops. The low cost of generic medications may actually improve adherence to the medication regimen, but there can be difference in formulation and efficacy from the brand name product. Geriatric patients may have difficulty in adhering to medical advice due to various reasons, and they may also be more susceptible to the systemic effects of medication, particularly beta blockers and alpha-2 selective adrenergic agonists. Although there is lowering of intraocular pressure physiologically during pregnancy, pregnant glaucoma patients may still require anti-glaucoma medications, but there is not much data regarding safety of ocular hypotensive medications in pregnancy and lactation. Nasolacrimal occlusion, gentle closure of eyes, and lower concentration of drugs are recommended during pregnancy, and brimonidine is a preferred agent in pregnancy but should be withdrawn before delivery and should never be used during breastfeeding. Beta blockers and systemic carbonic anhydrase inhibitors are contraindicated during pregnancy and breastfeeding. Compliance with medical advice is a major issue in success of glaucoma therapy, and compliance can be increased by educating the patient regarding the potentially blinding nature of the disease, the benefits of treatment, possible adverse effects, and irreversibility of pre-existing vision loss if any, by prescribing a simple treatment regimen which the patient can understand and follow, which may include scheduling drop instillation with routine daily activities such as meals and brushing teeth, and by instruction regarding follow-up schedule. After initiation of a drug, IOP should be measured 1 to 2 months later depending on the drug, and following achievement of the target intraocular pressure, patient should be followed up every 4 to 6 months to ensure stability of structural and functional glaucoma status. And at each follow-up, the patient should be asked about adherence to treatment regimen and occurrence of side effects if any. Prostaglandin analogues are the most common first-line agents in medical therapy of glaucoma. They decrease intraocular pressure by 25 to 33% by increasing uveoscleral outflow. Latanoprostene bunod, a nitric oxide donor, also increases trabecular outflow. They take 4 to 6 weeks to produce maximal effect, and they are prescribed once daily in the evening. Side effects of prostaglandin analogues include darkening of iris and periocular skin, hypertrichosis, periorbitopathy, and increased risk of cystoid macular edema and reactivation of herpetic keratitis. Beta blockers decrease intraocular pressure by 20 to 30% by decreasing aqueous production. They lower intraocular pressure within 1 to 2 hours of instillation, and they are prescribed twice daily. They are less effective when the patient is already on systemic beta blockers. Side effects of beta blocker therapy include worsening of asthma, COPD, bradycardia, and heart block, as well as CNS depression. They may worsen myasthenia gravis, reduce glucose tolerance in diabetics, reduce HDL levels, and provoke hyperthyroidism on abrupt withdrawal. They are contraindicated in patients with asthma, COPD, and bradycardia. Brimonidine, an alpha-2 selective adrenergic agonist, lowers intraocular pressure by up to 26% by decreasing aqueous production and increasing uveoscleral outflow. It lowers intraocular pressure within 1 to 2 hours of instillation. It is prescribed 3 times daily, and side effects of brimonidine include follicular conjunctivitis, contact blepharodermatitis, CNS depression, and in young children it may cause apnea, bradycardia, and hypotension, so it is contraindicated in infants and young children. Carbonic anhydrase inhibitors lower intraocular pressure by decreasing aqueous production. Topical carbonic anhydrase inhibitors reduce intraocular pressure by 22%. They are prescribed 3 times daily, and side effects of topical CAIs include burning on instillation, and in eyes with compromised corneal endothelium, they may cause corneal decompensation. Systemic CAIs can reduce intraocular pressure by 33%, but they are reserved for short-term use because of their adverse systemic side effects such as paresthesias of fingers and toes, renal stones, sickling crisis in patients with sickle cell anemia, sulfonamide hypersensitivity, blood dyscrasias, and hypokalemia in patients receiving thiazide diuretics. Systemic carbonic anhydrase inhibitors are contraindicated in patients with sulfonamide hypersensitivity, hepatic and renal impairments, and sickle cell anemia. Parasympathomimetic agents are used infrequently at present because of their side effects. They lower intraocular pressure in open-angle glaucoma by opening the intertrabecular spaces by contracting the longitudinal ciliary muscle, and in angle closure glaucomas they act by contracting the dilator muscle of the iris. Presently their use is restricted to plateau iris syndrome, aphakic glaucomas, pigment dispersion syndrome, and for induction of intraoperative meiosis. Side effects of parasympathomimetic agents include meiosis and ciliary spasm, increased risk of retinal detachment, and infrequent occurrence of systemic side effects such as bronchospasm and atrioventricular block. Parasympathomimetic agents are contraindicated in phacomorphic, malignant, and inflammatory glaucomas. Rho kinase inhibitors lower intraocular pressure by 20% by increasing trabecular outflow. Their most common side effects are conjunctival hyperemia and corneal verticillata. Fixed dose combinations have similar IOP lowering efficacy and side effects as compared to administration of the component drugs separately, but they help in increasing compliance to therapy and also reduce preservative toxicity. Hyperosmotic agents lower intraocular pressure by osmotically dehydrating the vitreous cavity. They start to lower intraocular pressure very quickly, and their effect lasts only for a few hours. They are used for acute management of severely elevated intraocular pressure. Their IOP lowering efficacy depends on the amount of the drug administered and the rapidity with which it is administered. The major adverse effect of hyperosmotic agents is acute congestive cardiac failure due to increase in cardiac preload. So hyperosmotic agents are contraindicated in patients with renal and cardiac issues. Medical therapy of most glaucoma patients are initiated with a single agent. If this single agent fails to achieve the target intraocular pressure but lowers intraocular pressure significantly, then another agent is added. But if the first agent fails to lower intraocular pressure significantly, then it is changed. Addition of a third or a fourth drug decreases compliance, increases the risk of adverse effects occurring, while usually showing only a modest further IOP lowering. Ocular surface damage is an important issue in medical therapy of glaucoma. If ocular surface damage occurs, drugs with safer preservatives or in a preservative-free formulation should be prescribed. Artificial tears should be added to the regimen, and if ocular surface damage is severe, laser or surgical treatment options for glaucoma should be considered. Nasolacrimal occlusion and gentle closure of eyes for 1 to 3 minutes immediately following instillation reduces systemic absorption and adverse effects and increases the proportion of the administered dose entering the eye. Lower concentration of the same drug and less frequent dosing also reduce systemic adverse effects while maintaining efficacy of the drug in many patients. These steps are particularly important for beta blockers, alpha-2 adrenergic agonists, and topical carbonic anhydrase inhibitors, which may have significant systemic adverse effects. Compliance is a major issue determining success of medical therapy of glaucoma. Compliance can be improved by educating the patient regarding the blinding nature of the disease and benefits of therapy, prescribing a simpler medical regimen which is easier to follow by the patient, and instructing the patient regarding the importance of follow-up to ensure stability of structural and functional glaucoma status. It has been a long session, and thank you for listening.